I'm happy to welcome our first panel, Aging Today, Who Are We Creating Policy For? Please come to the stage. First and foremost, I'm so pleased to introduce Dr. Jeannie Fogelston-Benek, Associate Director for the Program of Medicare Policy at KFF, who will be moderating today's discussion and kicking it off with a data-driven look at today's aging population. As a reminder, you can find Jeannie's bio along with the other bios of our panelists in the digital program. Welcome to Jeannie and the other panelists.
And I will introduce my fellow panelist, Sandra. Sandra is a participant in the People's Say project, and she will share some of her personal experience, bringing some personal insight to the data that we'll talk about today. We have Alana Knudsen, who is the director of the Nork Walsh Center for Rural Health Analysis. And finally, Natalie Keene, who is the director of federal health advocacy at Justice in Aging. And I'm going to just start us off with a couple of slides today to set the stage. So who are we creating policy for? So just a couple data points to help ground us today. The share of the population in the US that's 65 or older, so qualifies for Medicare on the basis of age, is increasing rapidly. So those numbers are actually reversed. In 2010, it was 13% of the population. We are rapidly increasing, so in the next couple of decades, we'll be up to a quarter of the population. Similarly, the share of the population that is 85 or 80 or older is also increasing, and we haven't quite reached the cusp of that increase. So in 2010, it was about 3% of the US population, and we're gonna reach about 8% in just a couple decades. And that has implications for something we will get a little bit into in terms of what Medicare covers and doesn't cover, especially with respect to long-term care. So I'm missing a slide.
Yeah.
Okay, so I'll just tell you. So the Medicare population is diverse. Many enjoy good health, but many also have limited financial means and have challenges, health and cognitive challenges. So for example, 50% of the Medicare population has an income of less than $36,000 a year. Recent work that we've done showed that about 12% of Medicare beneficiaries, that's over 7 million people, spend more than 10% of their income on Medicare premiums. And so even though Medicare is very important in terms of covering healthcare services, it can be quite expensive for especially people with modest incomes and who don't qualify for Medicaid. People on Medicare have an average savings of less than $104,000. That's the median savings. And this is relevant when you think about long-term care. The average cost of a stay in a nursing home for a year is a little over $100,000. And so half of the Medicare population does not have the savings to pay for that. And it is not covered by Medicare. Over a quarter of the population has at least one functional impairment, a limitation in an activity of daily living. So going to the bathroom, getting dressed, things like that. About 20% report that they're in fair or poor health. A little under 20% are dual eligible, meaning they also have Medicaid coverage, which provides important wraparound services. It also brings its own challenges in terms of navigating two different programs to get the coverage. About 18% live in rural areas of the country. We'll hear a little bit more about that today, but there are unique challenges in terms of access to providers and services for these people. 17% have a cognitive or mental health impairment or mental impairment. And when we think about what Medicare program, this is something I think about a lot, looks like in terms of making decisions about coverage. Choice is great. Choice can be very challenging and overwhelming for a large part of the population as well. And we are talking about aging today, but I would be remiss if I did not mention that Medicare also serves people with long-term disabilities, and 12% of the Medicare population is actually under the age of 65. And so As I mentioned, Medicare is important for covering medical services, but it is limited. And as people age, they have more than just, strictly speaking, those medical needs. So it does not cover long-term care. It does not cover dental, vision, hearing. And so for people who are very low income, Medicaid provides some important, fills this in. Medicaid pays the Medicare premiums and cost sharing for most dual-eligible people. It also provides wraparound services like long-term care. Here, this is some work we did based on 2021, how many people who are full Medicaid eligible received a wraparound service from Medicaid. So just under 800,000 had institutional long-term care services. Over 2 million had home care services. Vision and dental are also services that people use, and non-emergency transportation, getting people to their medical appointments, is something that Medicaid helps fill in. And I wanted to raise this in particular in the context of the recent legislation or law that has passed. While it did not specifically target Medicare, many people on Medicare rely on Medicaid and other programs, and so thinking about aging in the future, thinking more broadly than just Medicare, some of the other programs that serve this population. So I am going to get us started with a couple of questions for the panel, and then we're going to turn it over to you all. So the title of the panel is Who Are We Making Policy For? What characteristics of the aging population are most relevant for policymakers?
Yeah, I'm happy to start off. So I think really focusing in, our focus at Justice and Aging are on low-income older adults, and just seeing how many people on Medicare and older adults in general have limited income, right? So 50% living on income of less than $36,000 a year. But, Medicaid is helping many of those people, about 1 in 5 Medicare beneficiaries, but there's still a big gap there, and affordability quickly becomes an issue for many older adults, and particularly with long-term care, when you see the savings that people have that can easily be wiped out quickly as soon as long-term care needs arise. And then also, in addition to Medicare having those gaps, I think it's important to keep in mind the population, and that people don't realize that Medicare doesn't cover these services. And, it's across America, but even among older adults, they tend to think Medicare will meet their needs as they grow older.
And in rural America, access is not only influenced by financial wherewithal, but actually geographical access to services. And over the past 15 years, for example, we have seen over 500 nursing homes close, in addition to over 130 rural hospitals close. So what that means is that people need to travel farther distances to be able to access care. And when you're looking at older adults that are hoping to age in place in a lot of these rural communities, they may not have those wraparound services, such as transportation, available to be able to take them to distant care. So I think as we look at policy, how we address older adult aging also needs to factor in the geographical proximity to those essential services that are absolutely necessary to be able to age well. I would also call attention to the issue of caregiving, and we heard that in our keynote this morning. A lot of older adults are aging in their home communities while their family members are living at a distance. And that creates additional challenges in being able to support their quality of life as they opt to age in place. So proximity to services and proximity to family and caregivers is on the forefront of older adult aging.
I'd like to take us back a bit and take a look at the baby boomer population, which is fueling this increase in older adults. I was born in 1945, so I started going to school with children from the baby boomer population. First through third grade, I only went to school half a day because the population had increased so rapidly. And I was speaking to a friend of mine who said when she was in high school, she's 4 years younger than I am, she had 3 shifts for their high school classes because there were so many students. My graduating class from high school was 900, hers was over 3,000.
Oh, wow.
And we knew those numbers then.
Yep.
Why are we now sitting here talking about, oh, the population is great, when we knew it how many years ago? So that was my first inkling on that. And then I kept asking, how do we care for older adults? And one of the things that concerns me is when my mother went to the doctor, whatever the doctor said, she did it. Nowadays, we have older adults who've been educated, who've been managers in various ways, women and men. So when you go to the doctor, it should be a partnership. It shouldn't be, do this, and that's because I'm telling you to do it. No. What can we do together? How do we work together for care? And I could go on board, but the other issue that came up for me was the fact that vision is not included and dental is not included. I have a friend who's a retired nurse. Dental care are early, when there's problems, it's early signs of hypertension. Blurred vision is early signs of diabetes. Those are key elements that happen to older adults, and yet they're not doing a holistic approach to care for older adults. So I asked my question to myself, are we saying that older adults don't matter? Or we couldn't have a vision for another century? I'll leave it there.
Thank you. So we knew this was coming. We didn't maybe necessarily know exactly what it would look like. Some of the data from from the speaker talked about the increased years in disability. Are there other key shifts that have taken place or you have observed that you think are important to keep in mind as we make aging policy?
Well, one of the ones that we see in rural America is access to workforce. And this is compounded by the unfortunate, I've been doing this for 30 years, working in rural health, and we have a 43% higher mortality rate for working adults, those 25 to 54, than urban. So we have an issue of having a healthy workforce in our rural communities to also be able to care for an increased number of older rural adults. And this is across the spectrum. It's not only within healthcare, it's in public health, it's within social services. It's also within a lot of those community services that really provide the opportunity for rural adults to stay in place. But I think one of the considerations we also have is to think about how our workforce can be arrayed in perhaps a different and more team-based way to really be able to support and meet those rural older adults' needs. And I think this is also apropos for urban. This is not just a rural issue. And just to give you an example, some of our rural communities now have over 33% of their residents age 65 and older. Just think of that. 1 out of 3 people in those communities are older adults. And some of those are still the people who are volunteering for the EMS, for emergency medical services, because in rural America, we rely on volunteers to provide those emergency medical services. So even though we have a lot of older adults, we're also relying on them for their volunteer and for their support of other, even older adults in their community to be viable.
And I'll just add that I think people, a big shift is people wanting to age in place and knowing that they can, but our policies and programs haven't fully caught up with that. a big example is in Medicaid, the home and community-based services are still an optional service for states to provide, whereas care in nursing facilities is required. And so that leads to a lot of bias towards institutional care in the way we pay for services, and then also, unfortunately, limits on who can access home and community-based services. And so I think, just looking forward, we need to really be thinking about investing in these programs, making sure that both Medicaid and Medicare are actually supporting people to live in place and age as they want.
So Medicare and Medicaid, what's starting to happen during open enrollment, there's this push for people to go for Advantage programs. And I'm going to give an experience I had with an Advantage program, which is what I had just prior to my Medicare. I had an emergency, went to the hospital, and my understanding, I went by ambulance. My understanding is that if the ambulance takes you and you're admitted to the hospital, there's no charge for the ambulance. But in that particular case, I was in the hospital a week and I got an ambulance bill for $1,500. Mm-hmm. The other experience I had was my doctor requested that I have an MRI. Mm-hmm. And when I called, because you have to get approval from Advantage, I got, no, you can't get that. And I said, but that's what my doctor requested. And I remember saying to the person that I was speaking to, do you have an MD behind your name? And they said, no, why do you ask that? I said, well, then how are you telling me that my doctor's request is not acceptable? Yeah. The Advantage plan is really just, in my opinion, a company that looks out for their bottom line. They become your primary caregiver and Medicare is secondary to them. And to push us over there because they're trying to save money in Medicare is, to me, it's unconscionable and just not wanting to care for older adults. And I'll leave this other point with you. The requirement to be eligible for Medicare is either 10 years or 40 quarters. I have worked 57 years and I had 228 quarters. I don't want to be treated as if I'm begging for something. I worked for it, I'm entitled to it. And I think that has to change. So.
We'll have just maybe one or two more questions and then throw it out to you all. I actually want to start with you, Sandra. You alluded to this a little bit in terms of maybe what people have overlooked since we have known that this was coming. Are there other things you think policymakers misunderstand about the aging population?
I think it's the big piece for me is the relationship between the doctor and the patient, and the dismissiveness at times. I mean, it took me 6 months to get an exception for COVID because I was allergic to the medication. But they wanted me to take something else. And I said, I'm not going to get killed because you just want me to do so. So there's this not listening to the patient. That for me is a big factor that has to be dealt with.
Makes sense. And then I wanted to just dive into, we've mentioned a little bit about people who live in rural areas and dual eligibles. Before we throw it to the audience, are there other just points that you want to mention or raise?
Yeah. Sure. Yeah, so I'm always happy to talk more about the dual eligible population. So by definition, these are people who have little income and resources and are generally facing economic security issues. They may be challenged on a daily or weekly basis about making decisions of how they're going to pay for their groceries and their rent. And, you know, many of them are relying, in addition to Medicaid and Medicare, also on programs like SNAP and other benefits to help them really meet their daily needs. They're also a more diverse population compared to the general Medicare population. About half of people dually eligible are people of color. Many have limited English proficiency, and over 60% are women. So a unifying factor among many people dually eligible is that they really have higher healthcare needs and higher rates of disability. So disability, as we heard in the keynote, does increase with age, but for this population, you know, even at a younger age, more disability, and they often need help with daily activities. And many people become dually eligible for Medicaid because they need long-term care, whether that's in a nursing facility or help at home, and Medicaid is the only source of coverage for that care. So Medicaid is really a critical complement to Medicare. Jeannie spoke about the wraparound services. Medicare is itself expensive, $185 a month for the Part B premium, in addition to coinsurance and deductibles. And Medicaid helps pay for those costs for over 10 million people. And really, without Medicaid, a lot of low-income older adults wouldn't even be able to access their Medicare. They wouldn't be able to afford to go to the doctor because they can't afford that coinsurance. So it's really critical in that way. And then it's also filling the gaps in the coverage that Medicare doesn't provide: dental, vision, hearing aids, as well as transportation to doctor's appointments. So, you know, Medicaid is much broader than traditional health insurance, and so it, you know, helps people get to the doctor, and then again, you know, most critically, that long-term care. And so these programs were enacted together. In fact, on the 30th, both Medicare and Medicaid turned 60 years old. Something certainly to celebrate. But, you know, they were enacted together, but not necessarily designed to work together, especially in today's environment. And Sandra spoke about the complexity. People who are dually eligible really face this. They're navigating Medicare and Medicaid, which are both complex on their own. But then they might be enrolled in a Medicare Advantage plan. Their state might enroll them in Medicaid managed care. Their long-term care might be carved in or out of that managed care. So that's a lot to be navigating. And we hear from advocates and people who are dually eligible that they want better care coordination and support with navigating these services. And from our perspective, key to that, though, is, you know, we want to be coordinating good and comprehensive benefits. So we need to be investing and strengthening both Medicare and Medicaid to make them work better, to fill in those gaps. And we're really concerned about the cuts that were enacted in the Budget Reconciliation Act and what that means for access to care for people dually eligible. Particularly access to home and community-based services. As I mentioned, those are optional services under Medicaid, and so when states' budgets are squeezed, you know, we know from history that is a place that they go to cut spending, and so that means less access to care. And I think it's just all comes together as there's a real difference between coverage and actual access to care. Yeah. People who are dually eligible have a lot of health coverage, but they often have barriers to accessing care.
Mm-hmm. And I would just pick up that thread that we have a higher proportion of rural older adults that are dual eligibles than in urban areas. But one of the considerations also is, again, related to that workforce. Home and community-based services pay for the time that you're in the home. They don't pay for what we call windshield time. So if you're ever working with rural folks and they talk about windshield time, it is the time that people drive from their workplace to the home and then back again. And that is not covered. And so for a lot of rural older adults, there is no access to home and community-based services because there is no coverage for windshield time. So that is a consideration. And as was mentioned, looking at some of these other programs are also absolutely critical to supporting rural aging in place. One of them is looking at housing. We have a dearth of old housing in rural America that isn't supportive to aging. We also have fuel assistance programs that many older adults rely on. I have interviewed people where they tell me they keep their heat at 60 degrees because their house leaks so much so that they can pay their premiums and retain their Medicare. So when people are making a distinction about heat versus paying Medicare, they often suffer. And their health suffers in the long run. Likewise, SNAP. We have a lot of people that rely on SNAP that are older adults in rural America. So all these different programs have really been supportive to be able to allow older Americans to reside in their homes. Another issue that I think a lot of our policymakers aren't aware of is that we are losing nursing home beds. And it's not just about closures. It's about shifting from skilled nursing facilities to assisted living. And a lot of those assisted living do not accept Medicaid. So in doing so, people spend down their resources, and by the time they are out of resources, their only option is to get to a nursing home. And again, we see nursing homes close, and when we interview especially rural nursing home providers, what we hear is that Medicaid reimbursement is inadequate to cover the costs that they have to be able to deliver the care that they really need to for that aging population. So I think there is not one policy that is going to address all of these issues, but I think we need to step back and look at the intricacies of how these different policies work together. And when you pull one piece out, it's like a Jenga. You pull it out and it can collapse. And that, I think, is what we're very concerned about when we look at different types of budget cuts and what that will mean for older adults, particularly those in rural communities.
Yeah, that's so true.
All right. Would love to hear questions from the audience. And start here in the green jacket.
Thank you. By the way, you guys were absolutely awesome. Very, very great. So thank you. So I'm Vicki Shepard. I run a Healthy Aging Coalition. And one of the things I wanted to add to the anniversaries is also the 60th anniversary of the Older Americans Act, which is a network for aging programs that is community-based. So one of my questions for you is, I've been listening to all the policy changes and budget changes. Do you know of anyone who is looking at what the implications are to these policy changes? What happens in rural communities? What happens with hunger, malnutrition? I'm just wondering, it just seems like we're making these policy changes, and as one who is an advocate, I can see us in a couple of years coming whining that the cuts are hurting, but nobody's really measuring and collecting the data in a uniform manner. So I wondered if you know if anybody's doing that, or I would love to challenge either the Alliance or somebody else in the room to take up that charge. Thank you.
I'll say at KFF, it's certainly on our radar. I think one thing, the home and community-based services and Medicaid is something we are going to be watching, seeing if there are changes as states submit their waivers to CMS. I think also looking at food insecurity to the extent that it is measured in the MCBS, there is, I think, a broader concern with some of the federal data sets and how hopefully those will continue to remain as useful as they have been. But those need resources. They need to be able to ask the right questions. And so there is a concern there about whether we will continue to be able to rely on the same data sources in the future.
I would also add NORC's Walsh Center, in addition to our broader organization, NORC at the University of Chicago. We have been working with foundations as well as partnering. Just in all we do, it's collaborative because there is just not enough resources. And I will be very clear, there are very limited federal resources to be able to track this. So I just want to lift up the support that we are getting from some of your sponsors today, including the John A. Hartford Foundation, West Health, the Commonwealth Fund, SCAN Foundation. We've had a number of foundations come to the table individually as well as collectively because they understand the critical importance of us being able to identify what this baseline is, but also to look at doing some modeling so that states have some information by which can inform their policy. Because if you look, a lot of these policies are going to be pushed to the state, and they don't necessarily have the data that are going to be able to really make informed decisions.
Yeah. And I'll just add, I think even before there's data available, we need to be listening to the people and hearing about the impact on the ground. That's critically important, and we'll be doing that at Justice and Aging.
All right, I think there were other hands right here.
Hi, I'm Kathleen King with Health Policy Experts. So I want to add on to what Sandra was saying. That is that Medicare Advantage, once you're in there, very difficult to go back to traditional Medicare. Almost impossible because any health condition is counted against you. So 100% Medicare Advantage, Congress needs to do something. There are good plans. Many people are in Kaiser and they love it, but there's other bad players, United and others, who are not doing a good job. What I want to raise is the issue of access to care because people are not able to use technology. So those of us who are younger seniors certainly have recent work experience, are able to get on the computer. But I was in the Social Security office the other day and really felt very bad because there was a guard at the door. You couldn't get in unless you had an appointment. There were people who had low proficiency in English, but there was also a woman who could spoke English extremely well, who was tremendously frustrated. I've called, I can't get an appointment, I don't know what I'm going to do. I mean, this is really, used to be that you would be able to get somebody on the phone and talk to them. So much of this now is become, you have to do it on the computer. And if you don't have a computer, you live in a rural access area and you don't have access, you are really in a very difficult situation in terms of wanting to talk to somebody, understanding the complexity of how these insurance plans are working and getting what you need.
Thank you. Are there other questions over here on the orange?
There. Hi, my name is Vanessa Joy Walker, and I'm here as a personal advocate, also as a representative of the Depression Bipolar Support Alliance and the Women's Health Advocates. I am 49 years old, but I feel like I aged early because I went into menopause at the age of 36 because of cancer. And one of the things that we are concerned in the mental health community, as well as in women's health, as well as in survivorship communities, is what happens to those of us that are aging up in an environment where we don't know what's going to happen. The earning potential that we have in our 30s and 40s is declining. Those of us, more and more people are getting diagnosed with cancer at an earlier age, which more and more people are surviving cancer. That means more and more people are survivors. There's a lot of survivorship discrimination. People are talking about mental health, but if you talk about mental health, there is discrimination when you then go look for a job. if they look you up on LinkedIn. I recently had someone from a leading women's health organization tell someone else, another woman, if you're applying for a job, tell them you have less experience because they will think you're younger. So these are issues that they're like comorbidities, right? They're not necessarily all medical comorbidities. They're medical and social comorbidities. And so my question for you is, what do we do? I don't expect you to have the answer, but I want to acknowledge that there are people that are concerned, right? And those of us that are in the advocacy community, that are working in a variety of different therapeutic areas, realize that aging touches every therapeutic area, right? And it's something that needs to be included as opposed to siloed. So number one, what advice do you have for us as advocates? And number two, are there things that you all are working on behind the scenes to address some of these issues?
Well, I know in rural areas, we are really looking at isolation and loneliness because it was exacerbated during COVID, but people have not come out of it. And so there's a lot of effort. There's an interesting project called the Rural Action Aging Network that is based out of Lutheran Services of America, and it is looking at some of the Great Plains states and having a network to be able to support one another and be able to bring people together that are at distance geographically. But I think there's a lot of concern about the whole issue of loneliness and isolation. What does that do to the health of the person, but also because there is such limited behavioral health, and it's very difficult to even get behavioral health, regardless if you're on Medicare or Medicaid, because there are just not enough providers.
And I'll just add, I think something you said about aging, touching all of these aspects of care and the interconnectedness, I think is something we need to raise up too. I often find myself saying there's nothing magic that happens when you turn 65 and all of a sudden you're older and need health care, right? We need to be thinking about people across the lifespan. And again, Medicaid's role in that. Medicaid also covers about 1 in 5 people ages 50 to 64. And there's research showing that people who are enrolled in Medicaid before they become Medicare eligible and retain that Medicaid coverage have better outcomes. And again, need to be investing in these programs, thinking about how things like work requirements and so on impact people in these complex situations.
And I'll just add, I think we're increasingly thinking about how other programs impact people who have Medicare, and the Older Americans Act and other agencies that provide services. It's not just about your medical health care coverage. We are whole people. We have other needs. And so we're trying to take a broader lens to think about those things as well. Recently, we looked at SNAP coverage, and 1/4 of Medicare beneficiaries also have SNAP, which was something I had not ever thought a lot about, but it's clearly important. If you don't have food, it's also going to affect your health. And so that program is vital for many people. I think we have time for maybe one question or two short questions. Go. Right here in the white in front.
Hi there. My name is Mary Flipsy. I have a startup in value-based care, but more importantly, I'm with the Healthy Aging Coalition with Vicki Shepard, who asked the first great question. I'm thinking about the title of this segment, which is, who are we creating policy for? There is, of course, the 17 million people, if that's what we're looking at, who are going to lose their Medicaid coverage over the next few years. But I wonder, and of course, that's the headline. But then there is the economic impact to the providers who will no longer be employed at the health system that will have to shut down, that and then there are cascading effects of folks not being able to meet their mortgages, their car payments, their college tuition payments. So that is a huge piece of this, right? This and Vicky's, question about consequences. So when I think about who we're making policy for, what is the consideration for that fundamental economic impact of this? Because these dollars, as we know, don't land on the Medicaid recipient. They're just like student loans. They skip right over that person and go to the institution. And here the institution will be deprived of that and then all of the benefit that comes from it.
Yeah, I mean, I think the first thing that came to mind when you started talking was in many places, hospitals are the largest employers. Healthcare providers play not just an important role in providing healthcare services, but they also live in that community. They contribute in other ways, and so it is all related. And I think it's a challenge. Other folks have anything to add?
Well, we are looking at the economic impact of nursing home closures and potential, if there are any kind of evictions from nursing homes, because those people have to be cared for. So will it go back to the family member, and then will that family member have to leave employment? Because the vast majority of families are two earner households. So there are some really dire economic impacts that, as you said, go far beyond just the closure of that particular hospital or that service.
I think one thing that, as I'm listening, is that as a country, I don't think we value or really pay attention to our older adult population. Once we get to a certain age, it's like, okay, put them over in the heap and let's go move on to the rest of them. So if we shift our thinking about our population and identify the older adults as a key element in our country, the service that we've given and the service that we continue to give, I think there could be some shifts.
Yeah. And we have 1 minute. I will actually throw it to the panel with any closing comments you would like to leave the audience with.
Well, when it comes to rural can be your incubator of innovation. Rural communities can change on a dime in ways that a lot of larger other communities can't. So I think we need to also look at the strengths and assets of all of our communities, be it rural or urban, to really identify solutions, because as we often say in rural health policy, there is nothing about us without us.
Yeah, and I will focus into on thinking about women and the impact of cuts and how we're supporting them and what that means as they age. So I think if we're supporting women as caregivers, supporting them in the workforce, providing them health care, we're setting them up for a better future as they age, and making sure that we're not forgetting about older adults, but planning with them and for them.
Okay.
Great. Well, thank you, everyone. Thank you.